Imagine the room violently spinning around you, a relentless physical chaos where up and down lose all meaning. That is what your patient is experiencing right now. As a clinician, your immediate priority isn't stopping that spinning. It is figuring out if the cause is a harmless calcium crystal floating in their ear or a lethal stroke occurring in their brain. Patients will present with extreme nausea, vomiting, and severe imbalance, regardless of the underlying cause. These overlapping symptoms create immediate cognitive overload, making traditional pattern matching highly dangerous. Relying on rote memorization won't work here. To keep the patient safe, you have to adopt a strict exclusionary algorithmic approach to triage. We can map out this diagnostic challenge using this 2x2 grid, setting the severity of the patient's symptoms against how medically urgent the condition actually is. Conditions starting in the peripheral ear often present with highly distressing, severe physical symptoms, but they are medically benign. On the other hand, central brain causes, like strokes, can present with variable or even mild physical symptoms, but they are highly life-threatening. Because severe symptoms can easily mask benign conditions, you cannot use how bad the patient feels to gauge their true danger. You have to evaluate the timing, the triggers, and their hearing. This flowchart outlines the overarching decision tree. Your very first step is separating central brain causes from peripheral ear causes. To identify a central issue, you need to look for the 5 Ds: diplopia, dysarthria, dysphagia, dysmetria, and dizziness. Spotting any of these signs points you directly toward a cerebellar stroke, a brainstem stroke, or multiple sclerosis. When you compare the clinical features, central causes frequently include these neurological signs, along with severe gait impairment and vertical or direction-changing nystagmus. Looking for these 5 Ds requires checking for subtle neurological deficits while the patient is actively vomiting and distressed. It is a high-stakes screen. Identifying these signs early helps prevent a stroke from being missed in the chaos. Vertigo paired with any focal neurological deficit is central pathology until proven otherwise. If the 5 Ds are absent, we move down the peripheral branch of our tree by asking our first question: does movement provoke the dizzy spell? If the vertigo is triggered specifically by changes in head position, like rolling over in bed, and lasts only for a few seconds, you are looking at BPPV. Identifying BPPV is incredibly useful because you can often cure it right in the clinic using physical interventions like the Epley maneuver. But you have to be precise. A patient with continuous baseline dizziness will feel worse when they move, but that does not mean movement caused it. Confusing the two risks missing deeper pathologies. Confirming short, strictly positional bursts is the only reliable way to isolate BPPV from other ear diseases. For patients with continuous vertigo that lasts for days, you move to the second major question: is there hearing involvement? If the vestibular nerve is inflamed, you get vestibular neuritis. The patient suffers days of severe vertigo, but their hearing remains perfectly normal. Contrast that with labyrinthitis. Because the labyrinth contains both balance and hearing structures, inflammation here causes days of vertigo along with distinct hearing loss. This crucial split relies entirely on the subjective reporting of a patient who is currently exhausted and nauseous. Despite the difficulty, assessing their hearing status is the mandatory dividing line to accurately separate these multi-day vertigo episodes. We also have to evaluate hearing loss in patients who experience recurrent attacks lasting minutes to hours, rather than continuous days. This timing points to Meniere's disease, which presents with a classic triad: hearing loss, ear ringing or tinnitus, and a feeling of fullness in the ear, alongside the vertigo. We must contrast Meniere's with a dangerous edge case, acoustic neuroma. This also presents with unilateral hearing loss and tinnitus, but it progresses very slowly over many years, rather than in acute attacks. The major problem here is that distinguishing Meniere's from a slow-growing acoustic neuroma requires a detailed, reliable, long-term patient history, which you rarely have time to gather in an acute triage setting. Adding a strict timeline to their tinnitus and hearing loss is the only way to avoid confusing a chronic ear condition with a cranial nerve tumor. We can consolidate this entire framework into a single rapid recall matrix. Seconds of positional vertigo means BPPV. Days of vertigo with intact hearing is neuritis. With hearing loss, it's labyrinthitis. Attacks lasting minutes to hours combined with tinnitus point to Meniere's, and vertigo with any neurological sign points straight to the brain. It is never the severity of the room spinning that reveals the diagnosis. It is exclusively the timing, the triggers, and the associated deficits. This rigid algorithmic framework is built specifically for time-poor medical students facing board exams and for junior clinicians who need a high-accuracy triage filter in the emergency room. It does have limits. Neurologists and ENT specialists will have to move beyond these shortcuts when evaluating atypical presentations or complex mixed pathologies. By prioritizing these specific inputs, you control the diagnostic output, building the foundation for reliable exam performance and high-accuracy clinical triage.